Begin, just a few reminders. We will be using the chat function for question and answer. So please send all questions through the chat box and feel free to introduce yourself. If you have any IT issues, send us a message through the chat. And the session is being recorded and your attendance is consent to being recorded. So thank you. So today we are on session 6, basic ICU care considerations. And as usual, we are pleased to have the following panelists and teachers with us: Dr. Francois Xavier, Liberata, Dr. Apollinaire, Dr. Venuste, and Dr. Joseph. And with that, I'll hand it over to Dr. Francois to get us started. Thank you so much for joining today.
Yeah, thank you, Alana. As you said, today is session 6 among the 12 sessions we will have in 6 months. Now, the 6th session is basic ICU care consideration. We are going to discuss with our 4 panelists. So before we go through the presentation, please, the audience and the stakeholders and the partners, allow me to wish you Happy New Year 2022, and I hope you had an enjoyable festival period from Christmas to New Year. And also I hope since now this is the first session in this year 2022, I hope to be together the whole year and hope to the audience to come with all concerned people, so that this year will help more our patients, as I'm seeing the COVID cases being in increasing trends. So today, as usual, we start by discussing a case from the usual case we are managing at our health facilities. This is a case of a young man of 46 years old with hypoxemia and respiratory distress. And as we are doing this COVID issue, and they're not having enough ICU beds everywhere in the country or even in the world. So what are the basic ICU care considerations you may consider in the place where we are before we get an ICU bed available to send the patient transfer? So the objectives of this remind us or call upon our responsibility to identify the minimum standard of an ICU, so that you will not always waiting to refer the patient before, even though you are not able to transfer the patient in less beds we have in the country. What can you, where you are, identify the key healthcare providers you may need, or discuss types of monitors you need also, so that you can discuss with your procurement system how many, which monitors you may need, so you can help your patient giving ICU care in the place ICU you may need. So which kind of specialized equipment you will need also, and the most common indications of ICU admission. Usually there is no ICU admission without ICU also complication. So there is the common complication patients also will go through. That is not just to admit, but also you want to help the patient, but there is, as long as the patient stay in ICU, the complication also are not minimum. Other things we ask leaders or you here on the session and the audience to see how you can develop and implement an ICU care bundle to your facility, so that you can know which category of patients may need to be in a space where the space dedicated for or designed for ICU cases. So that I think and I hope with our focal panelists here, we are going through, and at the end of this session, everyone will understand at least what does it need to have an ICU. People like to say ICU is a geographical placement, but it's not just that. ICU is really a critical space, a critical place, which will need to be prepared ahead and to know what to do in that ICU and know who is a patient candidate meeting the criteria to be in ICU. Next, please. Next, please. What is ICU? I call upon Dr. Apollinaire to go through and help us to understand what is an ICU. Thank you.
Thank you, Dr. Francois. Thank you, the team. I hope you had enjoyable festivity time. When we say that what is an ICU, it's not a market, it's not, it's a special place where, as you can see on your screen, there is monitoring, there is care, there are patients sick, there are everything. Next slide. Okay, as a definition of an ICU, it's a specialty staffed and equipped, separate and self-contained area of hospital dedicated to the management of the patient with the life-threatening condition after injury, after other complications. And those patients, they need special monitoring to overcome those life-threatening conditions. Okay, someone who is disturbing can mute his or her. Sorry, someone, Musozi, can you put off your video? Okay, that space also it provides special expertise and facilities to support vital function and use of skills of medical, nursing, and other personal experience in management of those problems. Know that those patients, they have life-threatening conditions, and then they need to be monitored whether on their condition for like their improvement or their worsening, so that intervention will be done on time. Next slide. Okay, as we have been saying, the ICU, due to those multidisciplinary, due to those different patients coming in, their staff also have to be like with the multidisciplinary background. When I start with the medical team have to be having like a leader who may be intensivist, specialized in intensive care management, or someone with skills and be able to manage patients who need intensive care. Also, he can't work alone, he's with other team. That one who is a director or the boss of ICU has to be able to give advice to patient management, to do administrative work, to do teaching for new recruitee, to student, to anyone coming to the ICU, to audit cases. If there is a mortality and morbidity, is the one to do audit, and the other activities outside ICU. Most of hospital, the ICU or intensivist is also one who is called when there is a resuscitation in the other areas like emergency, OPD, or in the other department. Next slide. Okay, the doctors or intensivists can't work alone in the ICU. There is a nursing staff. The nursing staff is is considered with the ratio of patient they have. If you have like 1 patient or 10 patients, it will be different from ICU with 20 patients. And then those nursing staffs, if it's an ICU for neurosurgery, will be different from nursing team from a medical intensive care unit. There is, as I said, there's many variables regarding patient, regarding severity of illness. All other considerations are the individual policies considering the hospital. For example, in a district hospital where they have like ICU, the nursing team is different from referral hospital. In referral hospital, they may be having different specialty. Then those nurses, they are trained in a different specialty, so that they can give a nursing care according to the consideration of the patient. Next slide. As I was saying, there are other staff who are key in management of those patients. Depending on the needs, physiotherapists, they are needed, because as long as those patients are bedridden, they need someone from physio to mobilize their limbs, to stimulate their lungs, and so on. We need also a radiographer, as long as you know those patients, they need to monitor how they are improving on the respiratory side, meaning that they will be needing X-rays. They need the dietitian. The dietitian, they are there to support the nutrition of those patients. Those patients, they can't talk, they can't do anything, but the dietitian may calculate what is needed according to the age, according to the disease. Also, we need other technicians like biomedical engineering to fix monitors, to fix ventilators. We need also social worker, because those patients, they need other staff or communication with their families, where social workers, they do. Occupational therapists, when they're recovering, they need someone to introduce, to initiate their normal function previously. They need interpreter in some conditions where they are multicultural people. They need someone to interpret. Pastoral clerical, they are needed in the case to preach for the family, in the counseling of family, to initiate some sacrament for patients. Also, sometimes we neglect some key person, those staff in charge of cleaning, or other staff around the patient, around our rooms where we work, because if they are not considered, they may unplug our vent, they may flush our water and farm the electricity, and that's why also we have to consider them and to initiate them and to work closely with them to show them what is the danger when we are working with them. Also, considering the ICU settings, we need also multidisciplinary other staffs. For example, if a patient is like developing diabetes, we need endocrinologists to help. We need radiologists if there is intervention to be done. We need all team as the hospital settings say. Next slide. Okay, let's go to the ICU equipment. Here I will be talking about basic equipment, because ICU is like huge. the equipment depends on patient condition or speciality of the patient. First of all, most of patients who are in the ICU, they need ventilators. Those ventilators also, they may needing invasive or non-invasive ventilation. Also, they need monitors to monitor their vitals, to know if they are improving or if they are deteriorating, so that intervention is done on time. They need suction apparatus so that if there is secretion coming, suction is done immediately. Also, there is airway access equipment, including bronchoscopy equipment to assist in the management of difficult airway. We need also in the ICU equipment, vascular access equipment, because those patients, they need IV line working, because it's where their IV fluid will pass, where the medication will be passing. Next slide. Okay, as long as resuscitation is concerned, we need materials for the defibrillator in case there is a cardiac arrest, so that you can know if like it's a shockable rhythm or non-shockable rhythm. Also for pacing if there is a bradycardia. There is, as we said, chest drainage equipment, because you know, as we'll be seeing, among the complication of invasive or non-invasive ventilation may be pneumothorax. At that time, we will be needing chest drainage equipment. We need infusion and specialized pump according to the medication we are giving. Some they need inotrope, some they need monitored fluid, other they need the special nutrition through the pumps. Those patients also will need transport means, because our CT scan have to be done out of ICU. If they need surgical intervention, they need to be moved from ICU to the theater. We need also some specialized bed where you can lift, turn, or weigh our patient, because most of our medication, they are like weight, they are dosed according to the weight of the patient. We need also other materials like ultrasound. We need, so that if there is a vascular access, if there is monitoring of lung function, that those ultrasound will help. And then, as I have been saying, special equipment depend on the patient needs. It's a neurosurgical patient, they will be needing other apparatus that will help to monitor, for example, intracranial pressure. Next slide. Okay, I can't leave this presentation without talking about ICU nurse patient ratio. Those depends on how our patient, they are critical sick. In a very critical patient, the ratio will be 1:1, one patient to one nurse, or one nurse to two patients. That will depend on the condition of the patient and what the nurse has to do to help that patient. For unstable patient who need like some nursing intervention or laboratory workup, as I've been saying, it may be also increased 1 to 3 or 1 to 4 if the patient who is stable and who need only monitoring, because one nurse can have a local 2 to 3 monitor if nothing needed as medication or other thing. Next slide. Okay, as I have been saying, the patient ratio in the most setting, it's 1:1 for all ventilated and other similar critical ill patients who need too much medication, too much aggressive management, and the 1:2 in the HDU or 1:3, depending on what the nurse have to do. I think that's the end of my presentation. I can give the speech to the next speaker. Thank you.
Yeah, thank you, Dr. Poner. I would like from the audience, if there is any question of clarification from what you presented of concern about ICU consideration in terms of staff, equipment, and ratio. So if there is anyone, as we must have interactive session. If there is any question or concern, please 1 or 2 minutes of a question to be answered, as we want the ICU care to be just starting from where you are.
Okay, I can add that even if you don't have an ICU, you know that you every time had like a very critical patient who need ICU, it's time to think about it. It's time to learn how, even if you set up an ICU, what are the equipment you will need? What kind of stuff do you need? This is a time, as long as we don't know, we have to set up or to give our hospital another special, because you don't know when you will need that. No, every time we had like a very sick patient, but this course may help even to plan what we need to develop our or to manage our critical patient.
Thank you. So I think there is no concern from the audience, So you set up your ICU, you have already prepared the place and the space from a hospital, and you need to give a critical care to a critical patient. And last time we discussed, last time we discussed about an ICU outside of an ICU, critical care outside of ICU. So now we are talking about how we can set up an ICU with requirements, minimum standard requirement. And then after we go through with Dr. Poner about the staff and the ratio and the equipment you need to set up your ICU in your hospital. Now let us, Dr. Venice, help us to know, after setting this ICU, what are indications to admit each patient to our set up ICU. Welcome, Venice, and Happy New Year.
Happy New Year to you, Dr. Francois, and to everyone in the attendance. Please confirm if you can hear me.
We can hear you very good, very well. 5 out of 5.
Thanks. So today, I'm delighted to share with you most common reason for ICU admission. So can we go to the next slide, please? Yes, critical care resources are limited and expensive. This is a common scenario in both developed and developing countries. So the appropriate utilization of ICU beds is crucial, and even if it is complex, so like having the nursing care team, having the medical team and other personnel, their morals may be of more importance than the intervention itself, which is can be offered in the ICU. So it's a complex because the care of a patient in the ICU can be influenced by many factors, and each factor needs to be taken into consideration. Next slide. I can say there are mainly 5 primary ICU admission diagnosis in adults. And the first main group is the admission is due to respiratory failure, which may be acute or chronic respiratory failure. And the patients need to be ventilated to have normal oxygenation. So the second most common indication for ICU admission in adults is acute myocardial infarction, which can give potential complications that can't be managed outside the ICU. We have also intracranial hemorrhage or cerebral infarction, the other main category of patients who requires ICU admission. We also have ICU admission due to percutaneous cardiovascular procedures, like placing a stent or doing angioplasty to try to correct the vascular blockage to improve the perfusion. So we also have another big category of patients who requires ICU admission, which is septicemia or severe sepsis, even without mechanical ventilation. Next slide, please. So other than those 5 big categories, we have other conditions and procedures that are requiring ICU in adult patients. One of them is poisoning and toxic effects of drugs, which can give either metabolic encephalopathies or patients became acidotic. They need support and monitoring in the ICU settings. We have also patients with pulmonary edema and subsequent respiratory failure. These patients, they may often need dialysis and they need close monitoring in the ICU. Also, patients with heart failure and shock, like patients in cardiogenic shock, they need vasopressors and these inotropes. They can't be offered easily and safely outside the ICUs. Those patients need to be admitted in the ICU. Patients with arrhythmias and other conduction abnormalities, they also need ICU for very close monitoring. Patients with renal failure with complications or comorbidities, they are also having life-threatening conditions. They need ICU admission as well. Patients with gastrointestinal hemorrhage with complications or underlying comorbidities, they also need ICU admission. Let's say you have a patient with bleeding from ruptured esophageal varices who might have spontaneous bacterial peritonitis or even hepatorenal syndrome. These patients are very critical. They need ICU admission for close monitoring. Another big category that we encounter for ICU admission, it's for patients with diabetic emergencies like diabetic ketoacidosis or patients with hyperglycemic hyperosmolar states. They have different clinical conditions that are requiring ICU admission, like fluid therapy, electrolyte monitoring, and other potential complications which may arise from those diabetic emergencies. Next slide, please. So the previous slides were for reasons for ICU admission in adults. Now for the pediatric age group as well. The admission for in pediatrics ICU, which is the PICU, It's either from acute illness or an exacerbation of the existing chronic condition. And respiratory conditions are the most common reason for ICU admission for pediatric age group, as well as we have seen in the adult population. So the median age for children admitted in the PICU, it ranges from less than 1 year to 1.9 years. And the most common indications are respiratory disease, cardiac disease, neurological disorders, like a child with status epilepticus, they need ICU follow-up and close monitoring. Pediatric children and infants who have severe sepsis or septic shock, they need to be admitted in the PICU for close monitoring. According to observation studies, we have seen that children with developmental delay, they may account as many as 38% in all PICU admissions. So you have to take into consideration the developmental delay when assessing children in the pediatric age group. Next slide. So regarding the neonates, they are either admitted in the ICU because of their prematurity, or they are born at term, but they have serious medical condition or surgical conditions. The majority of neonates who are admitted in the ICU, they are of low birth weight. The birth weight less than 1.5 kilogram. And greater than a half of all neonatal intensive care unit admissions, they are born at term and they have no more birth weight. So outcomes are improved for high-risk newborns and especially preterm infants born in facilities with a NICU. So whenever a newborn is having this low birth weight, they are at risk of multiple complications, and care outside the NICU can be complex and complicated. You need to admit them in the ICU to influence to have a good outcome. So the mortality in the NICU can be very high, from 4 to 46% in the developed countries, and in the developing countries, it is even higher. It can reach up to 64.4%. So these neonates are very fragile, and anything can take their lives. You have to admit them in the NICU as early as possible and start the treatment they need. Next slide. So before I conclude my presentation, I would like to give general elements that guide ICU admission in the overall. When you have a patient who is very sick and requires ICU, you have to judge if the expertise you need in the ICU is going to affect the outcome of your patient, and specific patient needs can be, if they can only be addressed in the ICU, you need to admit them in the ICU. But as we have seen in the previous session, in the critical care continuum, if you judge the intervention is urgent, you can start it even in the medical or surgical ward before transferring the patient in the ICU. You have as well to prioritize according to the patient's condition. and you have to, and this will, of course, depends on the diagnosis. If someone condition is not going to be improved with ICU interventions, you may decline ICU admission and give a chance to someone who has a high chance of survival. And these decisions are always from discussion in the team. If you judge, you need to prioritize when you have different patients who really need ICU admission. It is as well depending on bed availability, and this is a big issue in the developing countries where you have patients in the medical or surgical wards who might be in the ICU, but the beds are not available. You have also to assess, to be guided by the potential for the patient to benefit from the intervention. So the anticipated outcome, if it is good, you really need to support these patients to have a good outcome. I think this is the end of my presentation. I would welcome any question or comment from my talk. Thanks to everyone.
Yeah, thank you, Dr. Venuste. And I think after you discuss and the most common condition of admission in different population, adult, pediatrics, and the neonates. To my knowledge, in most of our Rwandan district hospital, they have what we call NICU, neonates ICU. But there's any place for adult and the pediatrics. So from here, the audience can help us to understand where they're working, what they are doing with the critical cases when they present, from one or two of the condition that you presented in your talk. The audience help us to understand what are you doing apart the NICU place you have for adult and pediatrics when they present to you. Can put in the chat, you can raise your hand. Yeah. In ICU, we admit patients with life-threatening condition and their complications. We did some interventions, and those interventions, some are invasive, others are non-invasive, but also with long stay, according to hospital stay in ICU, those conditions the patient has been admitted from may have complication. The procedure and intervention done by healthcare providers in ICU also may have complications. Some Liberata go help us to help people understand what are the complications for ICU patients who are admitted. It's not just to admit, you have to think ahead most of things regarding prognosis, outcome, as Dr. Venuste said on, and think about this complication before stressing people and saying that admit and admit without thinking about what will be the next after ICU admission. The ball at you, Liberata.
Thank you so much, Dr. Xavier. It's good to go through those common complications which will happen with ICU care. If a single patient is being treated with a multidisciplinary team, it means we have to expect or to anticipate some complications which may arise from the care, the intensive care that we are providing. Next slide. The first one is ventilator-associated pneumonia. The ventilator-associated pneumonia, it is a pneumonia which was not diagnosed on admission, but it happens because of the patient is intubated and the mouth care is not being done. So the tube that we have inserted to help the patient to breathe mechanically, it can chance of this patient to have a pneumonia, and this will be called a ventilator-associated pneumonia. This may be diagnosed between 48 to 72 hours. Match central lines and how long those lines should stay there. All of those factors can contribute to these infections and lead to poor prognosis. The DVT, this is deep vein thrombosis, which will end up causing the pulmonary embolism. Because of that immobility, a patient will end up by, like, the blood will clot easily because of immobility of those ICU patients. So there will be a need to prescribe some drugs which will help these patients to prevent blood clotting, like those blood thinners we always give to other patients who have blood clotting. Clients, whenever you go to one client, try to put on the aprons, you protect yourself, you do hand washing, so that you minimize the risk of bringing infection to one side to one patient to the other one. Then you have CAUTI. CAUTI is a catheter-associated urinary tract infection. Of course, if a patient is in the ICU, he's unconscious, he can't control the sphincters, and we need to monitor the input and the output of these patients. The catheter will be needed, but we need to know how will we care for them so that we prevent infection for our patient. There is a need to do daily care. I'm now focusing much on nurses, as I'm a nurse by profession. We nurses, we need to prevent this CAUTI by daily cleaning of that catheter, so that the germs will not keep accumulating there. I've seen somewhere that even the bags are on the floor. So those bags should be hanged on the bed so that they are not like a transporter for those germs from the floor. And we need to know when to replace the catheter. So most of the time they advise those catheters to be labeled so that everyone who comes in will know when the catheter was inserted and what can we do to minimize the risk of infection for our clients. Oversedation in the ICU, it may happen because a patient in ICU, sedation sometimes is quite necessary because we need to minimize the oxygen consumption for these patients, and we need the patients to rest, or a patient is in pain, we need him to be free from the pain, and sedations are used. So it's good to think ahead of time so that we can minimize oversedation for our patient. Malnutrition, sometimes the critically sick patients, the team is focusing on critically ill or critical condition, but malnutrition, the nutrition status of a patient is forgotten. So it's necessary for us at the team working to involve a nutritionist in our team so that this client will be daily assessed on nutritional status and be helped accordingly. Depends on how the client is. So there is what we call PICS. PICS is post-intensive care syndrome. This happens to people who are like survivors of ICU. If we are lucky to save someone from intensive care unit, we have to anticipate this complication which may come later in the future. And it's called post-intensive care syndrome, where someone will be developing, even some studies says after 1 year, they will be developing mental problems, anxiety, depression. You remember the invasive procedures which were done in ICU. So they are very traumatizing sometimes, and people keep that pain even after recovery. And when they went home, they go home, they will always think about the pain and the invasive procedure which were done for them, and this will like affecting them mentally. So we have to think ahead of time about this complication and plan to have like checkup with those who will recover from ICU. Medication error, of course, in a critically ill patient in ICU will be having many drugs. And if no attention is done, there will happen like those medication errors. So it's good, they advise when we are in ICU, we are not allowed to give any drug without cross-check with our colleague whom we are together. If I'm a nurse on bed 5, I can have like 1 minute to collaborate with the nurse who is working at bed 6, just to cross-check, confirm to me if the drug I'm going to give is the right drug, the dose is the right, the person is the right patient, things like those, the expiry dates, so that we minimize any error which may happen with medication administration. Delirium happens to most of ICU patients when they are recovering, and this is like they tend to have signs of and symptoms of which looks like the ones of mental health disorders, hallucination. They become violent, and sometimes they say that this is caused by sleep deprivation for this patient. You remember, this patient is in intensive care, and many interventions are being done for the client. The lights are on day and night, so the patient is not sleeping well. So they say that it's better to allow the patient to rest properly and to plan your interventions. We nurses, if a patient they have planned to do some blood sampling, to do some investigations like X-ray. So we are we are advised to plan those all interventions at the same time, so that we do everything and we leave the patient alone to rest. This can prevent delirium among ICU patients. Stress ulcers, they are gastric ulcers which comes because of stress in ICU. You see those painful interventions, procedures, the status of being in like, let me call it like an isolated place where many invasive and non-invasive procedures are being run to this patient. So the stress ulcers will arise. So it's better for us healthcare providers to think ahead and know how we can provide some prophylactic drugs for this patient to protect the gastric for this patient, so that those ulcers will not happen. So we have also organ dysfunction. The picture is showing the kidneys. This is why our patients from the previous talk is having catheter. We nurses, I'm back on nurses because we are the one to be with a patient many hours than even physician. And we are the one to advocate or to see alerts or warnings for some organ dysfunction like a kidney. If we have a patient in ICU with a urinary catheter and we find that there is no urine coming out, from here we have to know how to calculate a urine output for an adult person. If I have another person, I should know that the urine output should be between 0.5 to 1 mils per kilograms per hour. My colleague in the previous slide was saying we need to have specific bed in the ICU, which will be able to weigh our patients. So if you have a patient in the ICU, we should know the weight. If the bed are not able to weigh our patients, there is an estimated weight for another patient, and this is a standard. This is an agreement per hospital that you can discuss wherever you are and agree on the weight. How will you estimate the weight of another person? So if you have a patient in ICU, the patient is having a catheter, then you need to monitor the urine output hourly so that you will know, is my patient urinating normal way or there is like a decrease in urine output, which will be an alert for preventing organ dysfunction area or for collecting it area without causing more complications. Thank you, Dr. Xavier. I think this is what I would say about complications which may arise from the care that we provide in intensive care unit. Any question from the audience?
Presentation from just one slide or just one picture. And I hope our audience here understand now why admission is not just ICU admit. We have to think all over this. And the way we are in our different health facility or health setting, we have to think if we are having a patient or we are transferring a patient in ICU, think and explain to the families what we may expect to be from either outcome, complications, as we discussed here. So I think there are other many slides which you developed from this. So we can go over and then we wait, while Dr. Joseph come in to discuss with the ICU bundles, so that where you are in the different health facilities, we can continue to discuss always these things, and I don't think there is other thing to add on. So Dr. Joseph, you can come in, explain to the audience what are ICU bundles they can develop so that in their different facilities from now, I hope with the starting of this year, at the end, we may have an ICU facility, an ICU place in our different facilities, even 1 or 2 beds, just to think once we have a critical case, a patient who needs an ICU before transferring, what can we do in the meantime? Please, Dr. Joseph, come in and talk, discuss with us what bundles we may think before we start to think setting up our critical care unit in our hospitals. Welcome.
So, thank you, Xavier. Thank you, the whole team. Let's go the next slide to start with the bundle. Update those slides. Next slide, go on the ICU bundle. Let's continue.
I've talked about all of this. She can move on till the bundles.
Yes.
Thank you.
Okay, so thank you. As Xavier said, Joseph emergency physician as Ashibe again. So let's start by an ICU bundle. Next slide, please. So here, everyone know, so what is an ICU care bundle? So as a definition, a care bundle is a set of intervention that, when used together, significantly improve the patient outcomes. Of course, it's an ongoing process which is repeated daily until the patient status has improved. So next slide. So here we have some example of bundles, of course, ICU bundles. The first one is ventilator bundles. So, of course, this is a bundle which was created by ICU team. Really, it was created to prevent or those complications associated with mechanical ventilation, as the liberator said. So, another one is a severe sepsis bundle. Really, we will see this later. It's a bundle, as I say, a set of action, a set of intervention, which was grouped to decrease the mortality and morbidity from a severe sepsis. So another bundle which was set by the Belata is a catheter-associated UTI. You know, in our settings, especially in the critical care, we're having many UTI from those catheter line. Next slide. So this is a good example of 1 hour bundle, especially in the case of severe sepsis. So of course, it was developed by sepsis campaign, really to decrease the mortality and the morbidity from the sepsis. So initially for this bundle, of course, the medical emergency team, they recognize that the patient is in sepsis. That's first thing. You have to know if your patient is in sepsis or septic shock. And then, first of all, you get labs. So the first one to get your lactate level. So you know those lactate level, in the case of severe sepsis, they will increase, and they have a good clinical information, which is really important. So another one, at the second time, they get sample for hemoculture, blood culture, in the case of sepsis. And then they take this blood culture before broad spectrum antibiotics. And then after giving antibiotics, of course, you give fluid boluses. So in the case of severe sepsis, this bundle suggested to start by 30 ml per kg of IV fluid, crystalloid. So, and then after giving a fluid, of course, you assess your patient and you reassess. In this hour, really, if a patient is in septic shock, you may start vasopressors before everything. So this is a good example for a bundle. Of course, we can develop more bundle, but in our settings, we will see later this one. But this one, if done correctly, as those steps are followed each other in ICU, the patient mortality and morbidity from the severe sepsis or septic shock, really, it decreases. Next slide, please. So also, I don't delay on this.
Excuse me, Joseph.
Yes.
Excuse me, Joseph. In chat, there's someone who is asking you the meaning of bundle in a cheapest or summarized words. It's better to understand before going on.
So, okay, I saw this one is Jean-Felix Niomodemi. Is asking what is the bundle. As I said, so a care bundle is a set of intervention or action which are being repeatedly on the same patient who is meeting criteria, and then those patients being done maybe tomorrow evening or every day, so that the patient outcome can improve. So I can, as I was saying, on the sepsis, on 1 hour bundle for sepsis, you know, as you said, when you give you confirm that the patient is in sepsis. Then you start by laboratory, lactate levels, hemoculture, antibiotics, IV fluid, and then vasopressor. If the patient is in shock, it does or does a group of those activities or those actions as are grouped on sepsis. We're calling them a care bundle. I don't know if he's getting me very well before you continue. Okay. Okay, thank you, Jean-Felix. So let's continue on catheter-associated UTI. So as Madame Liberata said, also those are a set of activities or intervention really which needed to minimize those infection associated by those for the catheter. Of course, as you said, the first one, everyone should know all those guidelines for catheter removal. So what is required for catheter removal? So then to do it, it is aseptic insertion. How to insert a catheter on a patient, aseptic. So then use of regular assessment. So I'm not there on this one as Liberata talked on it. So, and then training for catheter care. So if you are in ICU and you are a senior or a senior nurse, a senior doctor, so it's your job also to train your young team also to be familiar with these bundles so that in your settings, in your ICU setting or your critical care settings, those infections related to for the catheter will be really minimal. Of course, that's what incontinence care planning. So all those activities, catheter removal, aseptic insertion, use of regular assessment, training for catheter care on your team, also incontinence management, is grouped together. Those activities are forming a bundle which was called catheter-associated urinary catheter urinary tract infection bundle. So it means in ICU where this bundle is stated, really everyone, it's followed step by step. I'm sure or UTI will be minimal in those settings. Next. Oh, thank you. So this is about development or implementation of a care bundle. As I said, those set a group of activities or intervention which are being done on a specific patient to minimize the risk and increase outcome. Of course, they can be set in every single hospital in our settings. So the first things is to understand the concept of the care bundle. Of course, as you know, there are many bundles: ventilator, UTI, precaution, sepsis, and others. Really, this can help in our hospital. Of course, it might be part of the standard in our practice if you agree on a set of bundle. So you know everyone here, we are working in the hospital, we can know really, and you can, which condition really, which is coming daily on our patient, and you set a bundle. We will see later how to we can make a bundle in our settings. Next slide. Okay, so during development of a bundle, really, as I said before, of course, you have to choose an issue of concern. So, and then we produce the scientific literature. You go in your background of your studies, library. So they say, what is the literature is saying on these issues? And then we saw some researches to compare the feasibility of that bundle. And then you will go in your clinical guideline. You know, every hospital is having the clinical guideline. You will see what your guidelines say on about that condition. And then if necessary, you will consult expert for more advice. And then you will set the protocol for each step of intervention. So you know, let's take a simple example. Just it's kind of an idea. Like take a kind of a simple cesarean section. You know, we're familiar with those in most of our DH. So you know, if we call it a C-section bundle, and you go say, if a doctor confirms that the patient needs a C-section, a need of C-section is the concern. And you go in your literature, scientific literature, to see what is the literature is saying about C-section. And you go in your researches, you see how the outcome, the benefit of C-section. And then you go in your clinical guideline, you say, so what our hospital guideline is recommending about the C-section. And then you may consult your seniors. And then you set a protocol, like I saying, before C-section. So we have to get, after getting consent, we give patient IV fluid. So maybe we cut hair, we do whatever. So the patient enter the theater, after theater, we do this. Then you say, after this time, we are sure our C-section was done perfectly based on those steps or those actions. This kind of a bundle just, I don't have a bundle of C-section, just I was trying to give an example of how we can develop a care bundle. Next slide. Okay, so really implementation is not really difficult. It's just a matter to explicit to make a tool with clear line or clear parameter. And then in that tool, every component really will be a vitals. And your bundle will be delivered on each occasion a patient meets a bundle criteria. And then, of course, this is a multidisciplinary team to deliver the best possible care to improve a patient care. So you can say one nurse will do it, another will not. That will no longer be, that bundle will be biased. So you need to be used every time you have a patient who meets criteria. That's principle. And then, of course, as a team, if everyone understand really, the bundle will really help very much to improve your patient care. Next slide. Okay, so here let's talk about post-intensive care syndrome. So really, if we remember what Madame Livrata said before, in ICU, really there are many complications and many derangement of our patient. This post-intensive care syndrome, really, it's any health problems that remain after critical illness. So those conditions, they are present starting when the patient is in the ICU, and they may persist after the patient is discharged from ICU to medical ward or surgical ward, then home. And those problems can involve the patient body, thoughts, or feelings. Of course, they may affect your family. Next slide. So really the clinical presentation of post-ICU syndrome, really it might show up uneasy muscle weakness, which is known as ICU acquired weakness. So you see a patient starting to be weak after discharge. Maybe you can think is not improving clinically, but already the condition which made the patient to be admitted in ICU was resolved, but your patient is still weak. So you will see a patient having thinking and judgment disturbance, which are called cognitive dysfunction. Of course, it might be presented as another mental disorder, as you know, a patient. And the literature said that up to 50% of those patients might return to work within the first year, but some may not. So really, this is a serious condition. Means it need close monitoring of those patients. So those are possible warning sign of this syndrome. So of course, I said muscle weakness, problem with balance, so problem with thinking and cogniting, really severe anxiety, depression, and nightmare. So those are, if you see a patient with such signs, please think about this syndrome. Next. Next. Okay. So this is a good question. What can we do as a family to minimize post-ICU care syndrome? So if you are a family member, so you may be able to minimize this syndrome by helping the patient, your family member, your patient to stay oriented. So you can talk about familiar things, people, and event. So you can talk about days, date, and time. So to a patient, if you know already your patient, you can bring some favorite picture, games, or some item from home. Really, if you know someone was interested in those, just bring it slowly, and you feel familiar with that. So if you are on the base of patient, really read or speak around so that he can understand his near their family members. Next slide. Okay, so this is called ICU liberation bundle. So really, this bundle was created in order to stabilize the patient in ICU, or to make patient in the ICU to be comfortable. You know, our ICU are having very noise, many machines which are alarming, many movement, many cries from different patients. Really, it's annoying situation. So this liberation day, so it's aimed to liberate the patient from harmful effects of intensive care unit, really to minimize pain, agitation, sedation, delirium, immobility, and sleep disruption in the ICU ward. So let's go below on the next slide to see the element of this ICU liberation bundle. So as I said before, of course, the first element is to assess your patient. You prevent and manage pain. So you know, most people are consulting hospital because of pain, and no one can say I'm comfortable with pain. So another element in ICU is to do daily spontaneous awakening trial and spontaneous breathing trial. So those trials are very easy. Just for spontaneous awakening trial, you come to a patient, you stop all sedative drugs on your patient, and you will see how the patient will react out of sedation. So this spontaneous breathing trial also is very easy. Just if a patient on ventilator, mechanical ventilator, you come in every morning, just you disconnect from a vent and you put on a spontaneous respiration, and you see how your patient is trying to make its respiration. So another one, really, another element which is crucial is the trace-off analgesia and sedation. Really, as you know, the aim of this bundle is to make the patient easy without pain. So if a patient really is free of pain and is not deeply sedated. Really, you can get more information about the clinical evolution. So another one is delirium. So the delirium really, it's a condition which can be, as Liberator said, is common in our ICU. Really, we have to assess our patient and we prevent and manage delirium. Really, here the key element is to know or risk factor of delirium in ICU. You know, there are many like drugs, those repetitive injection, those sleep privacy. So really, there are a lot. You have to know them, then you minimize those risk. Then the patient will get a less chance of getting a delirium. So another one is early mobility and exercise. Really, you know, a patient in ICU, they are bedridden. Really, we need to move them. Early mobility, make them exercise, moving them from bed to a chair, moving with the patient outside the ICU, they come back. Really, those movements are needed, you know, not only to prevent pressure sores, psychologically our patient, if are moving, really, it's helping them in this bundle. So the last one is to engage the family and the family member, give them a power really to be involved in the management of their patient. So it means if the patient is in ICU, really give a time, give a chance to the family members to be part of your management, so that the patient can't feel he's alone, he is in the prison of the hospital. So let's go to the next slide about implementation of these care bundles. As I said before, really we have to recognize our situation and we evaluate your hospital situation, and then we decide on what should be done. Next slide. Next, please. And then after that, of course, we need to take action. To take action really will be helpful. So as we try to implement, as I talked implementation before, there is called the CEDA approach. CEDA approach really, it's a kind of summary of what you say. And really, if you see, we're going to go through this, and everyone will try to see in his hospital setting to see if really we can implement those care bundles in our settings. So first of all, this S stands for situation. As I say, you recognize and you understand the situation. So, you know, all critically ill patient should be admitted or should be transferred for ICU management. So if you create a care bundle, it will help you to decrease some complication associated with critical illness. The second one is this E, stand for evaluation. You have to evaluate your situation, and then you will compare to the resource you have in your hospital. And then you will identify your resource gap. Here I can say maybe your healthcare providers, if they're needed. Of course, you will compare in your institution if really it's possible. And then you identify if you have the materials, monitors, equipment, physical space, really if they are needed. Of course, you will see if your materials really are ready and practical in your settings. Then you will identify a care bundle that can be implemented to improve your patient care. So also in your settings, you can make a kind of those catheter-associated UTIs. So sepsis bundle, ventilator associated pneumonia bundle, or other bundles. Of course, in your resource, you should identify those resources that will be the most effective in your settings. Just if you are in a DH, you don't have a big machine, you don't have a CT scan, just don't make those an impossible action in your bundle. Just it's very simple and easy. You make a bundle based on what you have in our settings. Of course, you will identify, of course, the barrier that will be faced. Of course, you plan how you will manage those barriers. Next slide on D. So this D, next. Okay, so this D stands for a decision. So after knowing your situation, after evaluating your situation, so just you will decide. On this decision, you will list the most common indication for ICU at your level. Of course, you will list or specialized equipment which is needed in your settings. Of course, you will need a patient monitor needed. And then you decide how you will close those barriers to change. So if you don't face a barrier in your settings, you will never change. You must be able to set those barriers and you see how to overcome those barriers. So the last one to be in action. So the action, of course, really you will start. You will establish a critical care committee. Remember in the last session, we talked about this. So most of our hospital, we're calling them the resuscitation committee team. Those are compared to critical care team. So then you will nominate your leader. You can't have a bundle without a leader. And then you advocate for equipment, of course, and training the staff, even additional education and training. Of course, you will make insist on policy and procedures in your settings. Then, if it does the system policy to be delivered in critical care, and those policy procedure should be available every time, on every patient if needed. Of course, it will prevent the most common complication which can occur in critically ill patient, as Madame Liberta said. And then after getting those, we will start to implement an ICU care bundle based on our resource and settings. So at this, I'm done my presentation. If you have any question, just come here and we discuss really on this ICU care bundle. Really, we need more input. Can give us your advice in the different hospital, so even you can help advise on what you can do in our settings to get those care bundle. Thank you.
Thank you, Dr. Joseph, and I hope the audience here understand the message you are delivering. And we hope they are going back home and they say that the institution with all these things which are listed here. If there is any question or clarification from the audience, today we discussed about what is an ICU, what is a minimum requirement to have an ICU, condition of admission, complications, what can we do to prevent those complications and then to improve the patient outcome. So is to go and create the bundle in each intervention in each area you are managing. And I hope this is really a good take-home message, and this is what we call assignment to go and do in your hospital where you are coming and where you are working. And this will help you to work in a really unorganized way if you are working according to policy and the standard you will set. So, and I hope, next please. I hope from this, the key we discussed here, next please. The key we discussed here is to know that the ICU is not just a transfer patient. ICU is that place where you decided to manage your critical patients with specially equipped and staffed for managing and monitoring of life-threatening conditions and complications. So that is what we have to go with. What is in general is nice. Next, please, next slide. I'm concluding our talk today. So as I'm saying, understand what is an ICU, is that place where in the hospital you have a specialized trained staff and equipment to monitor and manage the life-threatening conditions and complications, and where the patients are needs a specialized and continuous patient monitoring system. I don't know, everyone from us here in the audience, if you reflect where you are working, do you have this kind of critical care place or ICU place? Do you have this kind of behavior and the routine of managing this critical patient by continuous monitoring? If you don't have, as Dr. Joseph said in our SEDA approach, go and do advocate of the need, either staff, space, or system to be changed. So other thing, indication of the ICU admission, which are depending on resource availability. If you see that you don't have that resource, that is indication to transfer your patient, but not all patients are transferable because, as you know, in the country, we don't have that much ICU beds. So it's time now to have a kind of, as I said before, 2 or 3 beds where we have that place where we admit our critical patients. As you know, care bundles will help us to decrease ICU complications. Try to develop how do I insert the catheter IV, I mean the Foley catheter, how am I inserting the NG tube, what are mouth care of this critical patient who is not able to do his mouth care, he or herself. Understand that patient in ICU, you may think of the post-ICU complications and explain to the family after the discharge. Last time we were discussing about the critical care continuum, and we ended up from ICU to the general ward, then to the community, and then please, you have institutionalization of your guidelines in post-ICU care syndrome to our different families. And I thank you, everyone, and then invite everyone here that our next session will be in January, in 2 weeks, and we'll be talking about ARDS. And as you know, ARDS, in our time of COVID, just my voice changed. I was in our coverall. We have many patients in our ICU, COVID ICU. So people will understand better when we are talking about ARDS, how to manage, how to diagnose, what to do, as most of our COVID patients are dying from this kind of syndrome, not a disease, this kind of syndrome of ARDS. So be ready for the next session and call upon your colleagues. We are together to come more than today. And I hope, Alana is working and the IT team on delivering your certificates and the CPD. Whoever attended any session will get a corresponding certificate. How many sessions you attended, so you will get corresponding also credit. So to Alana and partners from either India or USA, please, this is your time. Thank you.
Thank you so much, Dr. Francois. It was a really, really amazing session. Thank you to all the co-panelists and all the participants. Thank you for staying through the session. We also want to appreciate our partners, ECHO India Project ECHO. We want to thank Dr. Anna Crawford of Stanford Medicine Division of Global Anesthesia for developing this resource. Thank you all. Please, like we always say, we have earlier put the link to the resource on the chat box, please feel free to go access the link free of charge. And just to buttress what doctor has said, we are really working on the CPD. We couldn't conclude because of the break. We also had a short break, but then we are working to ensure that we get it done before the end of the week. Everyone that has participated will get a certificate, but the CPD points are for those that attended the 3 sessions and stayed for at least 30 minutes per session. Those are those that are going to get a point for CPD, but certificate is going to give it to everybody for attendance, but points will be given to those that actually participated properly. That's it. Thank you once more. Like Dr. rightly said, the next session, that is our session 7, is coming on the 19th of January. Please tell your colleagues, tell those that are not here today, so please join us. As we've mentioned, it had their CPB points for joining these sessions. And if you have questions, please email us at echo@assistinternational.org, echo@assistinternational.org, and we'll attend to your questions. If you're not in the WhatsApp group, please indicate and we'll add it to the WhatsApp group. Thank you once more and enjoy the rest of your week.
Thank you too. Keep enjoying the new year.